is a danger signal. It's not a damage signal. Your nervous system and your brain will produce pain proportionate to how much danger it thinks you're in. In order for our body to control our movement, we have to get good proprioceptive input. But if we then get scrambled input, if a joint stops working correctly, that's now scrambling the input into the nervous system. That scrambled input may lead to, at some point when you need that stability, when you need that control mechanism, it doesn't happen. Sports performance relies on control and stability. All the research that suggests that actually pre-event stretching, if you're a runner or a sprinter or a jumper, will make you perform worse. There's very, very little evidence in terms of the warm down. There's good evidence for warming up, and it should include two things. So the best way of warming up for a tennis game isn't to do a lot of stretching of your glutes and hamstrings. I was riding my bike out in Italy. It was quite a narrow road. A young girl came around the corner in a Fiat Panda on the wrong side of the road and knocked me off my bike. I feel a pop in the outside of my left knee. They came back and showed me the x-rays, and I'd lost a third of my tibial plateau. I was discharged a couple of days later after that with the notion of, right, so complete non-weight bearing for 8 weeks. Surely it's not 8 weeks non-weight bearing. The prospects of a tibial plateau fracture are pretty horrific. And part of me is thinking, is this partly to do with the 8-week non-weight bearing?
Ulrik Sandstrøm is a chiropractor for over 33 years and has worked with top Olympians and national football and rugby players, helping them to enhance their performance and recover from injuries faster and prevent injuries. And these are precisely the topics that we talk about in this episode. Ulrik has quite a unique approach to performance and injury prevention. And so if you are at all into performance, whether you have a sport at any level, then this is definitely the episode for you. Let's get into it. Ulrik, how would you sum up what you do best and how you provide value best to those that are seeking your help?
So in terms of patients, I see my biggest value in actually getting people back doing things they never thought they'd do again. And, one of my phrases is always that patients don't come to see us because of pain, because most patients who come in and see us, certainly who come to see me, have had pain for a long time. So if pain was the trigger, they would have been to see, knocking on my door a long time ago. Normally they come to see me when that threshold of the pain is now interfering with their quality of life enough that they want to do something about it. So it's generally when the pain and the disability is preventing them doing enough of the things that they really enjoy doing. And sometimes that's been going on for a very long time. And I just love getting people back to doing those things again. And sometimes getting back doing things they never thought possible. And that's why I think goal setting initially with patients is super important to sort of have a target of what would you love, a question that I often ask them is, what would you love to get back to doing again? And so certainly in terms of patients, that would be my sort of main focus. Obviously, apart from being a chiropractor, I'm also an educator. And I see my biggest role in educating chiropractors or manual therapists in trying to help us understand what we do and how it works. Help us understand also when manual therapy or manipulation or adjustments may not be the thing that we first of all need to do with a patient, and also I think my biggest aim is to try and keep clinicians curious about what we do, and because I always struggle with the concept of people who sort of say, oh no, we need certainty in what we do. And I always find that as a clinician, the last thing I need in my life is certainty. I've been a chiropractor for 33 years. I'm now less certain than I was 33 years ago. But that's fine, because to me, that uncertainty and that curiosity drives further learning and further insight.
That tends to be the case, actually, as you start to learn more about really any topic, isn't it? They say the more you know, the less you know.
Absolutely. Yeah, and obviously Chris Chippendale, who I know you've had on the course, does this lovely graph of how you start to learn things, then you think you know it all, and then the more you learn, the more you you don't know, and then gradually you start building up knowledge and some degree of confidence in what you do.
Yeah, interesting. So how would you define chiropractic then after 33 years of practice?
That's a great question. I would define chiropractic as the ability to manually change neurology. Would be a big part of what we do, certainly in terms of our manual therapy. But I would also, certainly to me, a good clinician, whether that's a chiropractor or not, is someone who incorporates certainly manual therapy. I'm a huge fan of manual therapy. But also the sort of softer sides of things like communication, empathy with patients, and also an encouragement for activity. And we know that exercise and strength work and those sort of things are generally proven to be really important. So to me, it's combining those three things of manual therapy, patient communication and education, and then an encouragement to stay active and fit and strong.
And how do you then change neurology?
So I feel that actually most of what we do as manual therapists is changing neurology. And we may change mechanics, but a lot of the time actually that changing mechanics is actually changing neurology and neurological function and control. I use quite a lot of kinesiotaping now in my practice. I've always classed myself as an open-minded skeptic. And certainly when people first started putting flimsy pink tape on athletes and go, oh, this is going to help you, I was very, very skeptical at that point. But, I tried it, I tested it, and have seen incredible results. And at the end of the day, putting a bit of flimsy pink tape on someone's skin can only change neurology. It's not strong enough to support anything. What it changes is basically, is neurology. And in terms of how I think that the chiropractic manipulation or any manipulation or chiropractic adjustments work, I think it is resetting. And we certainly know that in terms of the effects of manipulation, we know that a reduction in muscle tone, particularly hypertonic muscles around a segment that we adjust, is fairly clearly evident now that will reduce, and that will reduce because of neurological function.
And I've seen some of your videos actually online of you doing pre and post taping.
Yeah.
And it's quite unbelievable actually, the change that someone had in their range of motion of their shoulder simply by, as you say, putting flimsy tape on them. So, I mean, maybe I've answered that question there, but maybe you can elaborate on how do you know you've changed neurology?
So again, I'm most of those who know me, they don't know that I'm a big fan of test and retest. I'm always slightly embarrassed to admit that probably for the first 5 or 6 years of my chiropractic career, I never dared ask a patient how they felt after treatment or retest anything. Because I sort of, I graduated from the ACC in 1991, very much a mechanical model, and there was an understanding of, well, we can't expect things to change. We can't expect patients to change immediately after treatment because they've had a problem for a long time. So things take time to change. But of course, the great thing about neurology is that neurology changes like this. But if we don't test and retest, we don't know that that's what's happening. So generally, I have sort of my 3 main focuses on testing is pain, range of movement, and strength. So by the time a patient leaves my office, I would generally want to document that we've had at least one of those 3 things change in terms of improvement in range of movement, reduction in pain, and improvement in strength. And the strength testing is basically with manual muscle testing. And because that, to me, gives us an insight into, did that patient change? So therefore, was my clinical thinking around that patient correct? Because one of my sort of the latest phrases I tend to use quite a lot, particularly when we talk about evidence-based care, is that generally in medicine, that's not just in chiropractic, is that some patients respond to some treatments some of the time. And that's about as good as we're going to get. That's not just us. That's medicine. That's surgery. We know, I was at a panel debate some years ago back in Denmark, and I was asked by the moderator, who was a healthcare journalist, of whether I still used acupuncture needles. And I said, yeah, I use acupuncture needles on some of my patients. It works for some of my patients. And he suggested, you can't have that. A treatment can't work for some people. That's the whole point of evidence, is that a treatment either works or it doesn't, which clearly showed that he was a healthcare journalist rather than a clinician. And of course, my question then was, well, why have we got over 40 different antihypertensives? If an antihypertensive medication worked or didn't, we would have one. But of course, if you had high blood pressure and you go and see your doctor, he will do an assessment, take a view, think, well, I think someone like you is likely to respond to this tablet. And then he will check up on you 3 weeks later. And if your blood pressure is reduced, he'll pat himself on the back and go, well done, I was right. If it hasn't reduced or you come in a huge rash, he will take that medication away from you and try something different. And it's exactly the same thing, but with manual therapy. I form a clinical idea of what I think is going on with the patient, and I will then treat them according to that. But I will then test. But I won't wait 3 weeks. I will test after my intervention and go, did that change the outcome that I was looking to change? And if it does, happy days. But the power to me almost is that when it doesn't, when I expected a change, but it didn't happen. We didn't see a change in range of movement. We didn't see any improvement in pain, and we had no better strength after that treatment. I'm already now thinking, maybe there's something I'm missing. Maybe I'm barking up the wrong tree. But I'm not 6 visits down the road thinking, why is this patient not getting better? I'm immediately questioning my clinical thinking and diagnosis.
Sorry for the interruption. I just wanted to ask for a very quick favor, and that is to simply subscribe to the YouTube channel, or if you're watching on Spotify or Apple Podcasts, then to follow. It's one of the best ways you can help to support this podcast and helps me to keep on making better and better episodes for you. Thank you so much for your support. Back to the episode. I think that's always been my frustration, actually, about the research model, because it is a very good model, and to really assess whether something is a coincidence or whether it's working. But as you very well articulated there, it very much falls down then when we actually have to remember that each and every individual is so different. And I say this a lot to patients. Sometimes 1 or 2 patients may say that it must get a bit boring just seeing spines all day. But actually, it's amazing how even it's exactly the same anatomy, everyone's amazingly different. Everyone moves different, everyone looks different, everyone adjusts different, everyone tests different, talks different. And so, yeah, it completely makes sense that the research model would have a bit of a problem there. I suppose it can give us an idea, but it really can't tell us, is that going to work for you? And I suppose what you're saying is, well, why don't we actually test it on you instead of the general public? Yeah.
Perfect summary of exactly how I look at things. And research to me, I'm a great fan of evidence, and evidence-based has very, very much changed how I approach things. I was once asked, what are you now no longer doing that you used to do because of evidence? And I can't actually think of much in terms of manually treatment. There's certain things that I use more of or less of. But certainly evidence has very much changed what I talk to patients about, my communication around patients, the idea of instilling a sense of optimism in patients. Pain science has sort of been one of my sort of latest hobby horses in the past 4 or 5 years, and of how important it is to get people on board with how pain works and how sometimes pain looks really, really scary. And again, as you touched upon on the research, is this idea that research gives us really good ideas of where would be a good place to start. Because at the end of the day, research is all about probability. And we know that you do a research cohort study, and it says that some people got better, some people didn't. And it wasn't statistically significant enough, so therefore we shouldn't use this treatment. Which of course doesn't make any sense, because there were still some of those people within that research group who got better. Maybe not for the reasons that we think, and that's all fine. But I know some researchers get a little, they start developing a bit of a twitch when you talk about the fact that it is down to n equals 1. So as a clinician, research gives me a great overview of these are tools that will have a likelihood of working with this patient. But it's down to me as a clinician to decide, well, what does Mrs. Smith need? What does the patient in front of me actually need, and how are they going to respond? And a huge amount of that will be down to my experience, my confirmation bias, but also testing and retesting. And we'll try to go, well, I think that this patient will need this. And this also boils down to this whole idea of the toolbox. And I think having a different set of tools can be really useful because it gives you somewhere to go. And particularly with the new advent of pain science, whenever we get a new thing developing, there's lots of people go, oh, we should only do this. And then there's also the other fraction that goes, oh, so pain science, that's all about just coloring in your pain and rating it from 0 to 10. And to me, pain science and pain education is just another tool that I have. And I have probably some of my most memorable patients, I have completely changed their lives. And the adjustment that I did wasn't to their spine. It was to their beliefs and their thinking around pain and what wasn't wrong with them. And I have literally had completely changed people's lives without doing any manual therapy. But of course, that doesn't mean that every person who walks through my clinic door needs for me to sit down and hold their arm and go, I realize how hard this is. If Steve the builder, who's tweaked his back yesterday, he needs an adjustment and to get on his way. But if someone comes in and they have such ingrained belief of how dangerous that pain is, and I had a patient who I asked her, what do you think is going on whenever you get this sharp pain? And she told me that, well, basically little bits of my disc keeps breaking off and severing my spinal cord, and eventually it's going to break in half. And of course, it's very easy to sit and think, well, that's ridiculous. But if that's her beliefs, no amount of manual therapy is going to make her any better until we take that away from her. And of course, that's when we then start having talks about this. And that's where people like, Christian Mateo is particularly good at how do we communicate that in an empathetic way and getting top side of that.
Yeah, I think that's completely right. And I think more and more we're seeing the importance of the mental side of things. And actually, the longer that I've been in practice, the more I'm recognizing the other aspects besides just physical aspects, particularly those that, if someone doesn't, I've now got to a point that I think if someone doesn't respond to my treatment, in most cases, I'm thinking, is there something outside the physical aspects that's going on? Because I've seen enough of these cases to know that usually you should see a response unless I'm missing something. Whereas at the beginning, you're kind of working everything out, but it just shows the importance of that. But I think there's a lot of people that would have listened to you there and been very skeptical on that fact. And I suppose that's the biggest barrier you have when you come across a patient like that says they got, I don't know, bone on bone, or these kind of phrases that that are part of the problem. How do you go about then addressing that?
Yeah, that's really interesting, and I we always make the joke that I can sit and tell a patient, right, this is not in your head, you're not imagining it. I do believe you, but you're not making this up. This pain is real, and then of course they walk downstairs and they tell my receptionist that Ulrik says I'm making it all up. So it's a difficult one to get across. You get a feel for who may be receptive to this. And actually, I've had a surprising amount of people, even people who I didn't think would get it, go, I was wondering about this. I was wondering whether I'm over worrying about this. And sometimes I have patients who, if I feel that they may not, they are so almost wedded to the idea of a physical problem, even if I feel that pain science would be a huge thing that we will need to get on top of, I may delay that. So I may do quite a lot of testing and on them, find functional deficits, and do manual therapy for maybe the first 3 or 4 or 5 sessions, because they will often need that too. And then if after 3 or 4 or 5 sessions they're now not quite getting as much better as they had hoped or I'd hoped, I'll often go back and then do some retesting. Because what then really happens is that you'll often think, oh, actually, this is more mobile. Do you remember how tight that was before? And oftentimes they won't. But that's when good notes are, oh, well, I have down here that, we had a 20 centimeter finger floor distance. When you try to bend forward, we're now down to 8. So we're clearly getting more movement. You can see how much stronger this muscle is. Do you remember how you really struggled with this when I first saw you? Oh, yeah, I could hardly lift my leg off the bench. See how that's really nice and solid now? Because that's a great way to go, well, so functionally you're getting better. So your body is responding and functioning better than it was, but your pain is still the same. So maybe we need to look at whether there are processes that means that actually our nervous system and our brains are exaggerating that pain. And then often they will be a lot more receptive, because you build up a trust over 3 or 4 or 5 sessions. You're not just a clinician who's just like, well, this is all in your head and your brain's making it up. So certainly with some patients, I find that delaying that a little bit and correlating with, well, your body is responding and clearly working better. Why is your pain not getting better? And that's when you start talking about pain. And one of the phrases that I really like is this idea of the pain is a danger signal. It's not a damage signal. Your nervous system and your brain will produce pain proportionate to how much danger it thinks you're in. And I will often send them the Lorimer Moseley video, the one with the snake, which I think just illustrates that perfectly. It's quite funny, it's quite entertaining, it's fairly short, and people get the fact that actually the brain is a massive factor, and that brings me into the sort of the realms of the classic maintenance patient that we see every 3 or 4 months. And before I started looking into pain science and how pain is processed by the brain, I was always puzzled by the patient who would come back. They'd be on 3 or 4 months checkups for years, generally coming usually and go, yeah, I feel ready. I've been just getting a little stiff for the last week or 2. And all of a sudden that patient walks in and they go, oh, I've been in real trouble in the last month. I've been really bad again, almost back to square one. You go, what's happened? Have you changed your job? Are you doing any new activities? Are you sitting more? Are you still doing your exercise? No, everything is the same. I'm still getting my walking in, and nothing has really changed. And that used to always puzzle me. And of course, now my next question is, how's your stress level? And so often they'll go, oh, yeah, my husband's losing his job, or my mum's dying, or all of a sudden there'll be a massive, and that to me is the biggest power of the pain science. It's helped me explain those situations. And patients will then go, so do you think stress is part of my pain? Well, of course it is, because pain is a danger signal. If you're under stress, your brain is now hypervigilant to anything that potentially may be dangerous, including pain. So it literally is going to turn that volume dial up. So that sort of analogy I've found really useful.
I've seen that a lot myself as well, that even, they come in as never seen the patient before, and then how did this come on? What happened just before it? Oh, my mum died, or there was some kind of stress, and then the pain came on. I've also seen or heard about the association, even with developing diseases like cancers, that sort of stuff, is that apparently it can be quite typical for it to come on just before a stress that hits your body, which is quite fascinating, and shows us and demonstrates partly that it's actually a wider cause, not just physical. And do you find, so just based on what you're saying there, because I can imagine, I'm trying to think if I've seen this much myself, but interesting to hear your thoughts, is when you show them, because I know I've got some patients that they actually struggle to see the improvements. I can see it, but they struggle to see it. So when you show them that, actually this test is improving, and these bunch, and then they go, oh yeah, actually, I suppose I am improving.
Yeah.
Do you find that they get better after that?
That's a good point. And yes, sometimes they do. I would tend to always incorporate it in, well, if your body is physically improving and functionally improving, but your pain is still the same, that shows us that there's probably a bit of a pain processing issue here. And then we start talking about what pain is, how our brain is literally producing pain as a response to stimuli, and that how we have this volume dial that our brain can either go, oh, there's something going on in here, but it's probably not dangerous, so I'm not too worried about it, and then it just turns it down. Whereas, of course, the lady who felt that bits of her disc was severing her spinal cord, as soon as she felt any signal or twinge in the lower back, that would be turned up to 11. Because her brain thought something very, very dangerous was happening with her back. So they therefore wanted to protect her. But yes, certainly, I think once we start talking about that, patients are much more likely to improve. And this whole idea of that we can work with pain, just because something hurts doesn't necessarily need to mean you need to stop. And that's, again, it's definitely one of the narratives that I have changed. Because I very much used to be oh, it hurts when I do this. Well, maybe stop doing it or do something different. Whereas now I'll go, well, how much does it hurt? And that's can sometimes be a groundbreaking question. Literally, how much? Because to patients with chronic pain or with a lot of pain amplification, basically pain is pain, and the idea of almost rating it. Means, oh, so you can have more pain or less pain, almost becomes a bit of a breakthrough. And I often say, well, if your pain stays within sort of 3 to 4 out of 10, you're fine, and you're perfectly safe to carry on. Well, it starts hurting when I walk, so I stop walking. Well, maybe carry on walking until you get to 3 or 4 out of 10. Have this little deal with your brain, go, okay, I know this is really scary, but 3 or 4 is safe. So, I promise you, if it gets beyond 4, we'll stop. And gradually you start, your brain goes, oh, actually, wow, I did go for a walk and it did hurt, but I was okay. And those are often the little breakthroughs that we get with patients that way.
You've spent a lot of time with athletes. You've worked with football club, rugby clubs, Olympians. One thing I want to get to next is physical performance. How do we optimize performance? So we've spoken a little bit about how we get people out of pain. Let's start with, what is chiropractic's role with optimizing performance? So this is now talking about beyond pain. Yeah.
So to me, that all boils down to this whole concept of control and how our body controls movement, which again it does through neurology, and particularly eccentric control is a key neurological protector from injury and also improvement in performance. So essentially, whenever we move, we're sort of point and shoot machines as human beings. So if I wanted to bend over and pick a glass of water on a low table and drink it, that's all I focus on. Obviously, in order for me not to fall on my nose as I do that movement, billions of computations have to go on in my nervous system to keep me stable. My whole posterior chain, my hip stabilizers, my lower back stabilizers, my scapular stabilizers, all have to work in order for me not to break down doing that movement. And that all happens via eccentric control. We know from lots and lots of studies in sports that most athletes will injure during the eccentric phase of loading. So most athletes will injure not when they push up from a jump, but when they land. Classic ACL injuries are landing injuries. There's lots of studies showing that people who've had ACL reconstructions have faulty landing mechanics. So if we put them on a force plate and stick a video camera on front or on the side, we sort of do a single leg box jump. So they jump off box, land on a single leg, and we'd expect them to stabilize that fairly quickly. And on the ACL reconstructed leg, they stabilize a lot slower, and they will also tend to have some valgus varus sway when we video them. So the conclusion often is that, when you've had ACL construction, that leads to poor landing mechanics. I would almost flip that and say, well, maybe it was the poor landing mechanics that caused you to blow your ACL in the first place. And you've done my muscle testing course many years ago. You'll probably remember the Michael Owen video of Michael Owen, the famous footballer, kicking a football. He's on the pitch in a World Cup game against Sweden. He plants his left leg, kicks with his right, and collapses and literally tears his knee. His ACL, MCL, and posterolateral corner all goes. And of course, the question there is, why was that? Here's a footballer kicking a football. Here's an athlete doing a movement they've done time and time and time again. And all of a sudden they now injure. And to me, it was a lack of control. So it was lack of stability, lack of eccentric control, which is normally from some sort of neurological scrambling. So something mechanically or muscularly wasn't working well. Because in order for our body to control our movement, we have to get good proprioceptive input. So our nervous system is always looking for where are we in space. And in order for it to do that effectively, all of those sensory organs and nerve endings and muscle spindle cells and Golgi tendon organs feed into our nervous system about where's this muscle, where's this tendon, how much load is it under. And then we'd make an appropriate predictive correction to, okay, that's how this movement should stabilize. But if we then get scrambled input, if a joint stops working correctly, if we have myofascia that isn't working correctly, it may be hypertonic, there may be adhesions or scarring within those areas. That's now scrambling the input into the nervous system. You may still feel perfectly fine, but all of a sudden that scrambled input may lead to, at some point when you need that stability, when you need that control mechanism, it doesn't happen. And to me, that's where we as manual therapists and certainly as chiropractors come in order to try and look at mechanics, look at neurology, and certainly I use a lot of manual muscle testing when I deal with athletes. The great thing with that is that it becomes very obvious when someone is lacking control. And obviously, the bigger the athletes, the more obvious it is. I've spent 12 years at Leicester Tigers Rugby, and certainly with most of those players, you can't cheat with your muscle testing because most of them are far bigger and far stronger than I am. So therefore, if you all of a sudden find them doing a movement and you can literally with two fingers push that leg down, here's the problem with control. And to me, that control, we then need to find, okay, what is it that's scrambling? Is it a joint? Is it a sacroiliac joint? Is it a lumbar spine? Is it a hypertonic muscle? Is it a trigger point? Is it fascial adhesions or irritation that's irritating that area? And is that where we then go in and treat? And of course, we then find an area, treat it, retest, and see if that had the desired outcome. And certainly in terms of performance, we know that most sports performance relies on control and stability. We need a good, solid, stable core, in particular, and hip stabilization and knee and ankle stabilization in order for that to happen. And so often, I'm sure you've had it as well, we see an athlete, it may be an amateur athlete or a weekend warrior or a runner who's been injured for a while. They may come in and see you with a hamstring. And we treat the hamstring, we look at what's happening, knee, foot, hip, lower back, get the mechanics and the neurology better. And then they start getting back into running again, and they go, how's your hamstring? You go, yeah, no, hamstring feels lots better. And I've just knocked 90 seconds off my 10K time. We all see this. And of course, my response will often be, yeah, and I bet you didn't even try. They go, no. And of course, it's that whole idea of input and output. If you have poor control and if you have poor stability around, hip, knee, lower back, you're not going to get that solid kickoff that you would on a run when everything is nice and tight and stable, which of course is emphasized by the idea of all the research that suggests that actually pre-event stretching, if you're a runner or a sprinter or a jumper, will make you perform worse. Which sort of makes sense when we sort of strip it down. That running is controlled falling. So you've got a forward center of gravity. You swing your leg through, your foot hits the ground, to then propel you into the next stride. And obviously, the more power you have in that propulsion, the quicker you're going to be. So it almost makes sense that a slightly shorter, slightly bunched muscle will react quicker and stronger than, and really give that explosive force that perhaps if you spent 10 minutes stretching your glutes and your hamstrings out, you're going to get more of a boing rather than that really short explosive force. So to me, it all boils back to control. And certainly with all of my athletes, regardless of their sports, manual muscle testing and testing that stability and control in different positions is sort of the mainstay of what I do.
Yeah, that would surprise a lot of people, because I think if anyone is of any age at all, they would have spent a lot of their teenage years stretching before they did their sport. They were made to do that during football or PE or whatever it is. And now you're saying, or now the research is saying, is that actually you're almost more likely to get injured because of that, which is interesting. But what about flexibility? Because, what's the difference between stretching before and, let's say, stretching because you want to increase your flexibility? Do you think that could decrease your chances of injury?
Again, most of the research would suggest not, research always changes, but generally the hallmark of stretching research should suggest that stretching does one thing. It makes you better at stretching. But in terms of injury prevention, in terms of performance optimizing, it probably has very limited role, or certainly that's what most of the research suggests. If you see, warm up for a Premiership rugby game or a Premier League football game now, no one really stretches anymore. They all go through dynamic warm-ups, and certainly when I was working in rugby, warm-up would be very different from each player, So the number 9s and number 10s would be warming up very differently from the front rowers, because we know that warming up essentially is partly you're getting warm, but it's also grooving your nervous system into what are we about to do. At 60-70% of your effort, because that sort of A, gets you warm, and B, starts grooving those neurological patterns that you'll be relying on. But one of my sort of observations and new theories about range of movement and flexibility is that it all boils back to control. And I've seen it, the first few times I saw it, probably 6-8 years again, working with some of my rugby players. And there was one of our England internationals had been away, I think it was the Six Nation, and the England rugby physio rang me up and said, well, can you just have a look at this player when you come back? There's a bit of a shoulder issue. We'd like you to check him out. So he came into clinic. I checked him through. He had a bit of a shoulder issue, and we were testing his subscapularis strength. And generally, the way that I test that is in this position and have them push towards the floor. On the side that he had a shoulder issue in, he literally got to here. Not really any pain, but it felt like he couldn't really push it any further. On the other side, he had pretty much 90-degree internal rotation. So I thought, okay, well, we'll test the subscapularis in that position. We tested the muscle, very poor control. He was really weak. And again, this is a 16-stone rugby player. So looked back, found that he had a significant sort of CT junction, upper thoracic issue. We adjusted that. Went back to try and see if that was what was scrambling his control of his subscapularis. Got him on his back, and he immediately went into this. And of course, he went, "What's this?" We tested the muscle; it was now fully strong. So, to me, the theory behind that is that subscapularis is a major stabilizer of the shoulder girdle, and if that is inhibited or scrambled in terms of not providing control, your body will only go where it has control. So your body will only let you go into a movement that it knows it can fully control and stabilize. So his nervous system was literally going, I have no control in this area. I'm not going to let you go there. So to me, that's how a lot of these sort of issues with control comes in, and it's actually made me rethink what we do as chiropractors in terms of manipulation. And one of the videos that I show now is, the sort of classic. I think it was even Steve the Builder, and who came in acute low back pain, asked him to try and bend forward and touch his toes. He got just beyond his knees, felt it really tight in that right lower back, sort of lumbosacral into the top of the glute. And then, I adjust I think it was his L5. We get him back and he immediately gets 10, 15, centimeters further towards the floor. And of course he goes, well, that feels different. I said, well, what are you feeling now? Nothing really. And the way that I used to think about that was, how did we create that much more movement? What happened? What did the manipulation do? And of course, when I looked at it very mechanically, I said, well, we got more movement in his facet joint. So it's very good evidence that an adjustment creates more mobility in the facet joint. But would a little bit more movement in his L5 facet joint create 15 centimeters of extra forward flexion? So the way that I think about that now is, what we basically did, we gave him back control. So what was happening before, that L5 facet joint was jammed up. He was really hypertonic around that musculature, which means that his nervous system's input from when he was flexing forward, he will need certainly a lot of his posterior chain to be firing up appropriately. He had an L5 that was locked, paraspinal spasm and hypertonicity around that area, and that was literally shouting loads of bad proprioceptive input into his nervous system. So as he bent forward, his nervous system was going, I don't know where I am. I have no idea where this lumbosacral spine is, because all the normal input that I'm getting is completely scrambled. I'm not going to let you go. And we adjusted his L5, and we know, very good evidence, that adjustments can improve segmental range of movement, and it also massively reduces segmental hypertonicity. So that adjustment in my head wasn't about creating mobility. It was about reducing the scrambled input. So all of a sudden, he now had good mobility, reduced hypertone. So when he then went to bend forward, his nervous system went, okay, I've got this. I know where my L5 is. I know where that position is. I'm going to let you go because I have control of that movement. And that's certainly something that has changed probably in the last sort of 5 or 6 years of how I'm thinking about what it is that we're doing. And very often, whenever I see a deficit in strength on manual testing, I'll often relate it to a change in range of movement, and the two are so often coordinated and correlated.
Yeah, interesting. I think we do quite often look at the body quite simply, don't we? We say there's a tightness here, therefore we'll stretch it. Yeah. Or going back to that ACL injury, the ACL snapped. What's wrong with the ACL? Okay, we'll just mend it, and then we'll go back and hope it doesn't happen again. It's the same with ankle injuries as well. We know if someone twists their ankle, then it's usually if someone's twisted their ankle, you're like, how many times? It's not like once, is it? Because often they've healed from it, but they've not actually fixed the cause of the problem. Yeah. So we talked a bit then about what chiropractic's role is to some degree in helping with that side of things. What's the most important thing that someone or an athlete needs to do then outside and before, and let's say after doing their sport? What's the main thing to concentrate on? Because I'm assuming, based on what you said, stretching really doesn't have any role in this.
Again, it all depends. It depends on whether, obviously, if you're a flexibility-based athlete, then if you're a gymnast or a martial artist, you will need to get to those ranges. So therefore, flexibility and stretching will have some role. A lot of my patients, a lot of my elite athletes love stretching. Should I then take it away from them? Well, maybe not, because we know that everything we do has a contextual effect, and if they feel better for the strength and they feel that it helps them, it may well do. I may suggest that they don't do a pre-event stretch, or maybe do much more in terms of a dynamic warm-up. In terms of stretching after, well, there's no real harm. So if they enjoy doing that, that's perfectly fine. There's very, very little evidence in terms of the warm down. So we all know about the warm up, and there's there's good evidence for warming up, and it should include two things: A, getting warm, so feeling your body temperature rising and you starting to sweat slightly, but also grooving that nervous system in terms of preparing it for what it's about to do. In terms of warming down or cooling down, the only real evidence is if you are about to do an above aerobic threshold exercise within the next 24 hours, neutralizing your blood and muscle pH with a warm down in terms of sitting on a bike or go for a gentle jog for 10 or 15 minutes after, can be effective, but mainly in terms of performance. But if you're not planning on doing anything really heavy tomorrow, there's essentially no real value in warming down. So going and have a cup of tea is perfectly fine. I love, again, my confirmation bias. Love all this latest research, because I never used to stretch and I never used to warm down. And of course, I can now sit here and go, see, I was right all along.
Yeah, exactly. I suppose. So one guy that I've got into recently, who I think is he does some very, very good work out there. I don't know if you heard of him. He's called Knees Over Toes Guy, and his philosophy is behind not just stretching, but strengthening in those flexible positions. So not just getting yourself really flexible, but you actually need to be able to get into those flexible positions and then actually be strong. So he combines the two together.
Yeah.
What are your thoughts on that?
No, I think that sounds like a great idea. And again, I guess what it boils back to is that idea of control. Yes. Because there's a phrase in sort of certainly strength and conditioning, and certainly in terms of rehab, you can't go wrong getting strong. And I think there's a lot of truth in that. I struggle to see situations where people could be too strong. We know that patients can definitely be too flexible. And we've all seen the yoga practicing low back pain patients who can put their palms flat on the floor, but who still have a lot of back pain. And they can't understand it because they do all this yoga, which is supposed to be good for their backs. And, you test their stability and their strength, and they have none. They're great at end range flexibility, but they have no control or power or strength. And when I then sort of talk to them about, well, maybe swapping the yoga for some strength work. And of course they go, but I love my yoga. I go, of course you do. You can out yoga everybody else. But maybe that means that flexibility isn't really your barrier to improving your spinal health. And then they go, so what sort of strength? Well, your planks, your Superman, your side planks. They go, I hate planks. Why do you hate planks? Because I'm really bad at them. Maybe that's exactly why you need to be doing them. So to me, it's all a matter of finding what is that patient's deficit? What's the lowest hanging fruit? And if someone can't do a Superman or bird dog without wobbling or falling over, they have a significant issue with control. Some of that can be improved with manual therapy, but maybe getting them doing some strength work on that is really important. So I think, again, the evidence is pretty clear around strength work, strength, conditioning, control, stability are really big factors in what helps protect us.
I know that for me, I spent a long time wanting to touch my toes, and every now and again, I would stretch it, get quite close, get bored of the idea. A month later, I'm exactly back to where I was. Up until just over a year ago, and this is when I heard about Knees Over Toes Guy and the concept of, well, how about instead of just stretching, you also do some strengthening? And I did a whole year of doing that, managed to touch my toe, in fact, managed to touch the floor. And now I might do a stretch routine at the gym, at the end of the gym, actually, not at the beginning. And I'll do that maybe once a week. And I haven't lost that flexibility. And I'm not really doing it that consistently. So that makes a lot of sense that actually so based on what you said there, what I've done is I've strengthened that muscle so that it's not sending as many danger signals. There's more control in that muscle. So the body's not saying we don't need to bunch up again.
Yeah.
Yeah.
No, and to me, the whole idea of, I'm a big fan of asking why. So I've got a really tight hamstring. Why? Why are your hamstrings tight? your hamstrings are only tight because your nervous system is telling them to. Muscles are stupid. They will only do what the nerve tells it to do. So I was teaching the students back in Denmark at the chiropractic university there, and we were talking about the stretching, and we had a bit of a break for lunch, and one of the students came up after and said, "I'm a gymnast. I've suddenly developed really tight hamstrings. Should I not be stretching them?" I said, "Well, no, if you're a gymnast, flexibility is important. How long have you had tight hamstrings for?" Well, 2 or 3 months. And then, of course, well, why? It's not that she would be stretching deficient. That's not the reason for her tight hamstrings. So I actually said to her, "Oh, do you mind if we sort of haul you up in front of class and maybe work through you?" Because to me, working through a real live patient particularly in a muscle testing or a clinical scenario is really useful for conveying a message of teaching. So I always feel like I'm sort of slacklining a little bit because I don't know where it's going to go. I have no safety net, but it gives us really good thinking. And she said no, she was happy with that. So we got her up, and she got mid shin. She was a 23-year-old gymnast. And she said, "Well, I can normally put my palms flat on the floor." So I said, "Well, what are you feeling?" She said, "Well, my lower back feels tight and both my hamstrings feels really hypotonic." So I said, "Well, okay, let's check your control." So I didn't palpate her hamstrings. I didn't even check her SLR because I now had a finding that I was pretty keen on us changing. So I said, "Well, let's do some strength testing." So her QL strength, both sides, was incredibly poor. She had nothing. When we laid her prone and did a hip extension with some rotation, checking her rotational stability, she was really poor both sides. And again, 23-year-old gymnast. And she was sort of national level. So she had very poor posture chain control in terms of her QL and her rotational stability. So I'm now already thinking, well, maybe that's why the only stability she can create is by literally locking her pelvis in place with her hamstrings. So we assessed her spine. She had some TL junction issues. So I adjusted that, went back and rechecked. A little stronger, but not convincingly. Which sort of brings me back to whenever I certainly initially see a patient, I will only do one intervention and then I'll test and retest. In a clinical setting, after I've seen people 3 or 4 times, I'd be happy to do my treatment and then just come back and go, "Okay, did that clear everything?" But initially, testing what worked and what didn't work really helps my clinical thinking underneath. So the TL junction adjustment got some strength, but not convincing. And we then adjusted her L2 on the right-hand side. Bang. All of a sudden, everything fired back up. So her QL was super strong. Her rotational stability was where I'd expected for someone like her. But then, of course, we go back, well, what was the real test? Well, the real test that got us here was her finger floor. And she literally put her palms on the floor. And, of course, went, how did that work? And, of course, to me, I hadn't literally touched her hamstrings. But what we had done was we created better mobility in her lumbar spine, massively improved the proprioceptive input from that area, now given her back control of her lumbar spine, so her hamstrings were going to let her go into a movement that she couldn't previously control.
So just asking the question why.
Exactly.
That's
exactly
really good.
Yeah.
What's the most, so we've talked about a few things there in regards to how we can optimize performance and reduce injury. Is there anything that we're missing that we haven't spoke about yet?
No, I think strength training is a big thing. I think strength training, but making it functional.
Yes, for your specific sport.
Exactly that. Mm-hmm. And sometimes, I mean, we know that the McGill Big Three, they're not the most exciting. I mean, no one loves doing a Superman. But sometimes if you have really very poor control and stability, that is just the best way of getting it back. And but I will always link that into a goal. And I go, right, I know this isn't super exciting, but if you can give me 5 minutes twice a day, within 6 weeks, we'll see massive changes here. And I will then link it, and this is where you earn the right to get back to playing badminton again. This is where you earn the right to get back into your garden without crippling your lower back. So, you admit that, no, it's not fun, and there will be much more fun stuff that we can then get on to doing, but we sort of need to lay this foundation a little bit first. And that's where I find research is really useful. That's where evidence-based practice is really useful. My wife had a hip replacement last summer. So, of course, we knew that getting some glute control and strength was a massive priority. So I sat down and did some research. And it turns out that the most effective glute exercise out of clams and bridges and hip extensions is the single leg Romanian deadlift. That is the one that fires up all of the three glutes to the maximum event. So of course it meant that I could tell my wife, right, this is the one to do. You can do this, and you can do your hip hinges, and you can do everything else. But actually, if you really want bang for buck, this is the one that works. And then, of course, she completely ignored me because I was her husband. So she only started doing them when she found a YouTube video of her physio telling her that this was the right thing to do.
Do you know, it's funny, I find that because I create a lot of videos on YouTube, and what I now start doing sometimes with patients and friends and families, I say, watch this video. And I almost find that they're more likely to listen to me if they watch the video than if I say it in person. It's almost, my theory is that when you click on a video, you are the one initiating to say, I'm ready to listen.
Yeah.
That's my theory, but anyway, interesting point. But I know that certainly treating my wife is my hardest part.
No, absolutely.
So I know a few years back you had your own knee injury, and I remember following you on social media because you were posting quite regularly on your progress, what you were doing.
Yeah.
And it was quite thought through from what I could see.
Yeah.
Can you take us through what happened and then what really worked for you to recover as you did?
Yeah, it was. I was riding my bike out in Italy. We have a place out there. I ride this route very regularly. Unfortunately, at this point, there was quite a narrow road. I was keeping well into my side because there was a blind bend, and a young girl came around the corner in a Fiat Panda on the wrong side of the road and sort of knocked me off my bike. It was a fairly innocuous. She actually hit my pedal and then flicks me off the bike. I feel a pop in the outside of my left knee, and it was also a very interesting example of confirmation bias. And I thought, that's my LCL. I've done that skiing before. No biggie. 3 weeks, I'll be fine. So I sort of sat on the road. She came out. She was distraught and said, "Are you okay?" And I sort of, "Okay, I think I'm okay." My hands were fine. I hadn't hit my head. Just a pop in the knee, bit of a scrape. So I thought, probably LCL. I'll just check it out. So I walked across the road, thinking, no, this definitely doesn't feel right. Definitely LCL. She called an ambulance. I was probably in a little bit of a shock. Ambulance came. They took me to the local hospital. They wheeled me in, take an X-ray of me. I'm thinking, like, why are you X-raying me? Like, I've got an LCL. I think you'll find it's a grade 2C. I know this stuff. This is what I do for a living. And then, of course, they came back and showed me the X-rays, and I'd lost a third of my tibial plateau. Okay. And it was really interesting in terms of what we talked about pain science and how pain is a danger signal. If you'd asked me to rate my pain, from 0 to 10 as I was laid in the ambulance with a third of my knee having fallen off, I would have probably said 1 to 2. Because my brain had decided this is an LCL, it's no biggie, I'll be fine in a few weeks' time. So there was no panic that to my brain and my pain-producing pathways, there was no big danger because it wasn't a big deal. So then, obviously, they admitted me 2 days later. They put a big bracket of metal and 8 screws and pins to obviously get that tibial plateau back into position. And I was discharged a couple of days later after that with the notion of, right, so complete non-weight bearing for 8 weeks. I thought, this doesn't make any sense. So, right, fine. Yeah. So got back to the UK, contacted a couple of orthopedic knee surgeons that I know and say, surely it's not 8 weeks non-weight bearing. With what we know about bone healing and everything else and loading and healing, surely non-weight bearing isn't going to be the answer to this. And both surgeons came back and said, yeah, it's 8 weeks non-weight bearing because if the repair fails, you're looking at a knee joint replacement. So fair, I get that, but zero loading. So then I went to our old friend research. So I had plenty of time, started doing some research, and amazingly, I think it was 3 months earlier, there was an article published in Journal of Bone and Joint Surgery entitled Early Loading in Tibial Plateau Repairs. And they'd basically taken a group of patients, giving them the 8 weeks rest, and another group, and said, right, you can load when it feels comfortable. So just load to comfort. If it hurts, come off it, or if it's too bad, come off it. But as soon as you feel comfortable, start putting a little bit of gentle load through. And there was no higher incidence of repair failures in the people who loaded to comfort early. But obviously a much faster return to play. So I sort of said, right, okay, my goal would not be 8 week not loading. My goal would be that in 8 weeks' time, I'm back doing a full clinic. And obviously having the help of a Premier League football team, physio and facilities was useful. But to be honest, most of what I did was just stuff that I did at home. And I was really within 3 or 4 days just starting doing gentle plantar flexion into a gym ball, literally just to get a little bit of compressive force, because Wolff's law is still Wolff's law. Bone would only grow where it's needed, and I think I was fully loading within 4 weeks. I could actually walk without it wasn't pretty, but I could actually fully load and weight bear within 4 weeks.
And all you did was the pushing with the foot.
So pushing, but then also when I was walking, I was just literally gradually. In the first 2 weeks, it was very sore and very painful. But then after the 2 weeks, as I was walking on the crutches, I was just putting as much load as I comfortably could through that left leg. What I was also started doing was just getting on my bathroom scales to get a figure of how much weight, how many kilos can I push stand on my left leg, just to see, oh yeah, no, that doesn't feel comfortable. Because again, I could then gradually monitor progress. Oh, actually, can I put 50 kilos through this without feeling uncomfortable? So I did a lot of Compex, electrostim, work on my quads to keep them going, because my left leg was literally wilting in front of me. So I knew that keeping some strength there was important. I did a lot of general activity and strength, because one of the things that blew my mind, there's quite a lot of research that contralateral muscle strength has a spillover. So by doing literally, so with my left leg that was injured, so by doing single leg squats on my right leg, you actually strengthen your left leg too.
That's interesting, because is that to do with the cross-cord reflexes?
That's what we believe.
Yeah,
that essentially the nervous system is almost back to this idea. The nervous system doesn't really, often can't tell the difference between a real or an imagined load. We've all heard of the studies of people who sit in an armchair and for half an hour a day close their eyes and imagine themselves running, actually get fitter than people who don't. So this whole sort of nervous system trick. So I was doing lots and lots of strength work on my good leg as well, and then just getting loading and just gradually to tolerance, improving that tolerance.
Because one of the issues, or if you're not weight loading for a period of time, is that your muscles are only going to get weaker, and then that in itself is going to cause issues and slow your recovery. So one of the important things you did there then is to try and to keep that up. So you did electrical stimulation to the quadriceps, and then you were strengthening the other side, to try and affect the left side.
Exactly.
Yeah, very clever.
And I was doing a lot of, so I could do a lot of sort of prone glute with, so it was just sort of lie face down and then a TheraBand around my bad leg, because I could still do sort of hip extension and glute activation, because of course that was another thing that goes. And it sort of brings into question this idea of, because we know that the prospects of a tibial plateau fracture are pretty horrific. I think it's something like after 2 years, only 20% of people are back doing everything they used to do before the injury. So it's a pretty nasty injury and not great prognosis. And part of me is thinking, is this partly to do with the 8-week non-weight bearing? If you get someone who's in their sort of mid-60s, moderately deconditioned, and you now tell them to lie on their backside for 8 weeks, I think the reason why they don't never recover may not be because of the repair of the injury, but it's because they've literally now set themselves back so far in terms of muscle strength and control that they can never get back from that. So yeah, I did manage the 8-week back to I couldn't walk. I could stand and I could walk stairs pretty comfortably, but walking would still really irritate my knee. So even the 100 yards down the road to pick up a sandwich, I still had to use my crutches.
How long was it until you were off your crutches?
So in terms of walking off the crutches, was about 3 months. And actually, because we had because after 3.5 months, because that was my next target, we'd booked a holiday to Chile and to Patagonia. And obviously I wanted to do a lot of walking out there. And yeah, I managed that fine.
Yeah, wow, okay. So I'm about ready to hurt my knee, I think now, am I?
Yeah.
So yeah, I mean, I've heard that before now with, and it's the same is true with ligament sprains as well, isn't it? That it needs a certain amount of force going through it for it to actually heal correctly.
Yeah.
And that does make sense because the body adapts to what we do. So if we're resting, we don't do anything with it, it's going to say, okay, I'll adapt to you doing nothing.
Yeah.
So, but the difficulty is, of course, is that it's really hard to do that thing. So it sounds like then two aspects there is weight bearing and then keeping the muscles strong, or functional as much as you can. Yeah.
Yeah, and it was interesting because obviously we all know about the old RICE protocol. Rest, ice, compression, elevation. RICE became PRICE, which was protect, rest, ice, compress, elevate. It then became POLICE, where the R for rest basically got swapped out with OL, which was optimal loading. The latest integration of it, which has probably been around for 3 or 4 years, is actually now peace and love. So there's this sort of whole peace and love principles about acute injury healing. Whereas the first thing they need is peace, which is protect, educate. So educating our patients in terms of this will get better. I know it's really horrible. So again, getting that sort of mental aspect of it in control. A is for avoid anti-inflammatories, certainly in the first 48 hours. Some suggestion that we should even avoid ice, and that actually ice doesn't necessarily do what we thought it did. Because I used to also be one of those people who, if someone sprained their ankle or hurt their lower back acutely and they'd put heat on it, I would go, why have you put heat on your lower back? You need ice to reduce the inflammation. But actually the research suggests that ice doesn't really reduce inflammation and that ice is probably just another analgesia. So in terms of patients using heat or ice, I'm now fairly agnostic and go, try both, whatever feels most comfortable. Go with that.
Yeah, that's what I do now because I got this sentence. It actually might have been after I went to your seminar when you told me that ice wasn't as effective as we thought. I thought, well, I've been doing this for a while. Why didn't anyone tell me this?
Yeah.
But then I got the sense that, okay, it's not quite, we're not quite certain about this. And what I get with patients is that one will have a back issue and heat is better, and the other one will have the same back issue, but ice is better. So I tend to say, do what feels better. But my sense is that long term, probably not going to make a big difference.
Yeah, no, exactly. And then, of course, the C in peace is compression, and that's the real key. And as early as possible. And so
why?
So basically, what you want to do is you want to try and avoid swelling. So an inflammatory reaction is good, because you basically have lots and lots of good stuff that helps break down the bleeding and will help mend the injury quickly. So that stuff is good, but the swelling gets in the way. So an inflammatory reaction is good, which is why you initially don't want to dampen it down too much. So we've known this for many years. I mean, even 15 years ago when I worked at Leicester Tigers, an acute injury, we'd avoid anti-inflammatories for the first 48 hours. But compression as early as possible means that we will prevent swelling, because reducing swelling with compression is hard. Preventing it in the first place by getting literally just some tuber grip or some strapping tape or something around to that injury as early as we can to prevent it expanding is really useful. So early compression is really, really good.
So you're saying it's easier to prevent it than to, when it does swell, then
Exactly
to try.
Yeah.
But would that not be quite painful to have some compression on it?
So again, most of the compression will be to tolerance, and we will we use sort of elastic tape, cohesive taping, and it will still expand. But most of the time, it feels comfortable. And that's also when I use some of the taping. You may have seen the sort of fan taping with those sort of little strips, which again still blows my mind. There's still many things about taping that still blows my mind. And if it wasn't for the fact that I test and retested, I wouldn't think that it worked. But certainly that lymphatic taping, there's actually again quite a lot of evidence around that. It's probably one of the most evidence-based parts of kinesiotaping is the lymphatic drainage. And you've probably seen the pictures online of someone with a bruise, a whopping great big bruise, and they put strips of kinesiotape on, and within 24 hours, you can literally see the lightening of the bruise underneath where those strips were.
And is it just that you're sending signals to the brain, to that area, giving it some...
So some of the theory, again, is along sort of pressure gradients, that because kinesiotape is flexible, that slight crimping effect of the skin actually helps some of the lymph, the sort of subdermal lymph flow, is the current theory. They did a big study quite a few years ago in Australia in post mastectomy patients who ended up with lymphedema of their arms, and they compared the effect of wearing a full sleeve compression to kinesiotaping, and they basically had the same effect. But of course, for patients, it was much more comfortable, particularly in the heat of an Australian summer, to have just some strips of funky tape on their arm than to have a full sort of compressive sleeve. Despite
the compressive sleeve offering more compression.
Indeed, yeah.
Yeah, so that's a surprising result,
yeah.
Isn't it?
So essentially, the idea was that it sort of helped. So I used a lot of compression, but really for quite a long time. Obviously, got advice from the physios who were helping me at Leicester as well. And that, one of the interesting things is that you can never manage your own injury. I was pretty good at it. I generally class myself as someone who's fairly good at questioning my own confirmation bias and just sort of taking myself out of that equation as much as I can. But I wanted to get back on my bike fairly quickly, and I've got a static bike. I've got a walk bike at home. So I thought, well, great. That was, as soon as I can comfortably go through that range, I will, because it's going to help build me up some strength. So it did create a little bit of swelling after me spending 10, 15 minutes on the watt bike. But I thought I'll live with that in terms of getting some strength. So I spoke to Johnny, the physio at Leicester, and he said, "You what?" I said, "No, I'm on a watt bike. Does it cause a swelling?" "Yeah, a little bit." "Right. You do know about arthrogenic inhibition? So you do know that as the knee swells, it's now going to completely inhibit all your quads and glutes, so you will get no benefit from that training." I teach this. I literally make courses on this stuff. But it was interesting how my brain had decided to not remind me of that, because I really wanted to get back on the bike. But yeah, it was a very interesting exercise. I won't say that I'm glad it happened, but I've certainly learned a lot from it. I now have a 2-hour course on the peace and love principles, literally based around the principles of my injury. And it just goes to show that, early appropriate intervention and early appropriate loading is absolute key. And to me, that's what a lot of the manual therapy and the taping does, is it enables us to load an area up appropriately much earlier. And if we get appropriate loading, we get much better healing.
Mm-hmm. Yeah. Yeah. Okay. That's good. Yeah. I mean, I think that's what a lot of chiropractic does as well, is that we're not really healing an injury. We're just facilitating an environment for your body to be able to heal. Because I explain this a lot to patients, is that if you cut your finger within a week, usually that's healed. But if it's still there in 2 months, 3 months, something's not right.
Yeah.
So it's trying to produce that environment, isn't it?
Yeah, no, and I completely agree. And it was sort of the old cliche that the body does the healing, but it is the truth, And we have ways that we can hack into that and shortcut and take a lot of the barriers away in order that we can get back into function. Because again, function heals. Function and movement and loading is what helps us get back to where we want to be again.
And just to clarify on the NSAID, so the anti-inflammatory medications, so you said that it's actually not effective at the beginning, and is that because of what you're saying about the inflammatory process is actually helpful early on?
Exactly. So that inflammatory cascade, we need to get those macrophages and those enzymes and all those kicking in order to provide a healing process. So the inflammation isn't necessarily our enemy. It's the swelling that's the enemy, because the swelling causes tissue stretching, which then will delay healing. So if we can deal with the swelling in terms of the compression, then that will certainly help. And also, swelling causes pain, and also swelling causes inhibition. And so I think one of the biggest things, apart from the complex that I got from Leicester City, was the compression boots. There's sort of the big they're basically sort of compression. It's just a plastic boot that you put both your legs into, and then it is attached to a pump. And basically, what it does is it has 5 chambers, so it pumps the foot compartment full of air, and then the lower calf, and then the upper calf, and then the lower thigh, and then the upper thigh. So essentially helps bring back fluid. And I was laid in these probably 8-10 hours a day. And my God, it made a difference in terms of the comfort in my leg. It took so much of the swelling out and made the knee feel much, much more comfortable. It was interesting, a friend and colleague of mine, Donna Strachan, who I do the taping course with, when I told her about it, she went, "I bet you're going to the loo a lot." But actually, yeah, whenever I've been laid with this on for an hour and a half, first thing I need to go is go to the toilet. Yeah, I guess that makes sense, because obviously all that fluid's got to go somewhere. So yeah, that certainly helped me a lot. Again, just dealing with that swelling.
Yeah, and so then, what essentially you're doing is just try to put quite crudely, you're just trying to get rid of the waste products to then help encourage the immune system to bring what it needs to in that area. And I would assume then, just thinking logically there, that if there's a lot of waste material, as in your lymph and whatever else may be there, it's quite hard for the cells that actually need to do the healing to actually get to that area.
Yeah. And also obviously encouraging blood flow through, which also is, we know that so the love compartment of peace and love is load, optimism. Vascularization is a really big thing, and that basically means exercising. And it doesn't matter how you exercise. If you've got an injured shoulder, but you can still run or sit on an exercise bike, that's what you do. Because keeping your cardiovascular health and that perfusion doesn't just help you globally, it will help that area as well. So we know that doing whatever you can at that point in time, that will get your heart rate up and improve just general cardiovascular fitness, will also help your healing, simply because of increased blood flow and perfusion through the area as well.
What is the most important thing you do every day to keep yourself healthy now?
Eat properly, I guess, is quite a big thing.
We haven't spoken much about that, have we?
Yeah, no. So eating proper food. We all know about the problems with processed foods. I try and stay away processed food as much as I can. So certainly eating well, regularly exercising. So it's only actually really since my injury that I've started doing significant strength work, because I've just always found strength work so dull and so boring. I'd much rather go on a 3 or 4 hour bike ride than spend half an hour in the gym. So cycling and running are have always been my two main sports and ways of keep. So I've always kept fairly cardiovascularly fit in terms of cycling and running. But I'm now getting of an age that all of the research suggests that I should be doing strength work. I guess because of my build and my genes, I've always been fairly strong, so it's never particularly felt an issue for me. But I should be strength training, so I strength train now 2 or 3 times a week. I still don't enjoy it, and it's still I built it into routines now, so it's just something that I get up in the morning, then I go and do before I get a chance to decide that I can't be bothered.
Yeah, well, sometimes I think if you do something you don't enjoy, but you are seeing the benefits, it can be enough motivation for you to keep on doing it. Because I've done many things. I'm always looking for the next interesting thing to improve my health, but I will do it for a while. I classically have done this for a long time with supplements. I might take them for 3 months. Okay, I didn't really see any change with that. Right, scrap that. Why would I keep taking it if I don't see the change? The problem, of course, is that, particularly with supplements, you don't always know the change. There might be a change, but you don't always know. And that's where obviously the measuring or the testing, as you've talked about today, is actually really valuable. It's funny because I find that people are always looking for the next thing, the new thing. But your answer there was basically eat well and exercise. And it gets a bit boring after a while, but actually that is the most important thing, isn't it? It's not complicated. The difficulty is actually implementing it and doing it. Is the trouble. And I find that as society is progressing, the harder it seems to be to ensure that we're getting those two things, which means we have to pay more attention and be more active in those areas to actually keep ourselves healthy.
Yeah, and it's sort of it's finding, it's just that idea of developing habits. I'm quite a big fan of. I'm so bad with names, I forget the author, but the book Atomic Habits.
Yes.
I like the idea of that, is that, that if you do little things on a regular basis, then that becomes your habit. And also if you change the narrative, and I know I've said it, that and go, well, I'm someone who really don't particularly enjoy strength work, but I do it. So it's the, who do I tell myself that I am? And I basically tell myself that I am someone who does strength exercise. And of course the classic example from the Atomic Habits book is, you got 2 people and you offer them a cigarette, and one goes, no, no, thank you, I'm trying to quit. And the other person who's also trying to quit goes, no, thank you, I don't smoke. And those 2 signals to your own brain are very, very, very different. So I see myself as a strength exerciser, and so therefore I do it. And I think that the third thing again is being aware of your mental health. I'm fortunate in that I've always been quite good at taking a bit of a helicopter view of how do I feel or why do I feel this. I never really had to consider my mental health at all up until COVID, and ended up with a fairly acute stress episode as we were opening up the clinics. And it wasn't worry stress, it was literally just volume of stuff. We were running 3 clinics, lots of staff, lots of chiropractors, lots of receptionists, lots of patients who we all needed to do risk assessment for and keep safe. And I said, I've never had to even consider my mental health. But I had a sort of over about a week, and I was starting to think, I don't feel so good. I wasn't sleeping well, and all of a sudden I was sort of said, I'm lying here, I can feel my heart rate. And this tipping point, I was in one of our clinics, my wife, who's also a chiropractor, was getting one of our other clinics ready, and she sent me a text, oh, by the way, we also need to do this, this, and this, and this. And as soon as I opened up the text message, I got so dizzy I had to sit down. I went, wow. And because I'm fortunate that I could sort of distance myself, I wonder if this is stress. And so I actually put my blood pressure cuff on as I was in clinic, and it came back with a 153/93. It's like, wow. I think my heart rate was 80, and my normal resting heart rate is sort of 50 to 55. And it was really interesting because I almost felt better for that. That I could see an actual physiological response. So it wasn't just me being soft. Literally my body and my nervous system is now reacting. And so I just had to pull back, but it was difficult because obviously we had responsibility for staff and getting these clinics opened. Fortunately, my wife, who's an absolute machine, just soldiered on and said, well, you do what you can and have your breaks and take yourself out. So I think being aware of your mental health, and obviously some people need to work on that much more than others, but generally try to keep doing fun things. It's one of the things that I really enjoy getting back into my bass playing again. And there's this idea of flow, and that flow is an activity that you do that absorbs you so much that you literally can't think of anything else. And again, there's been some quite interesting research around stress and anxiety, and how using your brain's limited bandwidth, you can actually start tricking it into. Because a lot of people find exercise really, really useful for stress. I didn't, because I can still run and worry. In fact, when I'm running, I don't switch off. I hyperthink. I often plan my next lecture program, or what we're going to be doing next. Whereas if I'm playing bass, there is not capacity enough to deal with anything else. And actually, sometimes I find little tricks with patients if they feel themselves getting anxious, even doing mental arithmetic. And there's actually some reason interesting. Just do the 7 times table backwards, or start doing really complex calculations in your head, because actually you now block those other pathways out by literally, it's almost like pain gating, rubbing something that hurts, and tricking your brain into breaking up those pathways.
Distracting the nervous system.
Literally that. Yeah.
It's too busy to be able to therefore worry.
Yeah.
And then you can hopefully then try and break that barrier, I suppose. Yeah.
And again, I have done some meditation in the past. I find it tricky. I quite enjoy it, but I do some of the Wim Hof breathing, which I find really, really fascinating, really, really interesting. Again, some reasonable research around sort of just driving parasympathetic load through your nervous system, essentially reducing your stress responses.
Yeah, that's good. Actually, just literally the previous episode that is yet to be released, although when people watch this one, it will be, was on a breathing expert, and we spoke a lot about breathing. And but it just shows. I mean, a lot of the stuff I think we spoke about today, it just shows how it isn't just one thing; it is a whole variety of things. And then the other part is that everyone is very different. And so for one person, actually mental health might be 90% of your treatment, and you really need to focus on that. And the other person, it might be 90% physical. And this is why proper assessments is really important. And this is why I really love your outlook and perspective on life, in the sense that what you're really trying to look for is change. You're doing a test as you're going, getting measures as you go along to make sure that you are making changes. Because I suppose, one of the things, obviously as chiropractors, one of the main things we're trying to do is keep people out of pain. And as you said, to get them back to what they're doing. And in some respect, you could say, well, if they get out of pain, then it doesn't really matter. If they're back doing what they're doing, it doesn't really matter. But to help you go through that process and to get there faster, then doing those testings is also really, really going to be a helpful tool. So thank you so much for coming on. It's a real pleasure. And I mean, as we mentioned earlier, I went to your course a few years ago. I learned a lot, and I feel like I learned a lot in this session as well. If someone... question I normally ask at the end is if anyone wanted to get in contact with you for any reason. I know you're not actually in practice anymore, but you are still at the football club.
Yeah.
Is there a way they can follow you, etc.?
So generally I'm on most of the social medias. I have a slightly unusual name, so I'm pretty easy to find both on Facebook and Instagram, and I'm always happy for people to get in touch there. I run with my colleague Jesper Dahl. We run an online learning program called the Learning Collective, So that's the learningcollective.online. People can look that up as well. They can get in touch via that. We have a couple of your previous guests who are also, so both Chris Chippendale and Jake Cook. Both have got some great teachings on our Learning Collective platform that people can dial into and learn from as well. So yeah, we're planning on expanding that a lot, and yeah, we've had some really, really good feedback from a lot of our colleagues who really enjoy the program. We've got lots of things lined up for that as well. So yeah, people can get in touch through that as well.
Who is that primarily for? It's not just chiropractors?
So no, it's basically for manual therapists. So we are hoping to get, at the moment we've just got chiropractors on there, but I'm in contact with some physiotherapists, some strength and conditioning coaches, psychologists, pharmacists, those sort of people who can all deliver good online material. And the thing about all of us who teach on the platform is that we want theories, we want to teach concepts, but at the end of the day, it has to be applicable for Monday morning. It's the classic strapline of it's got to be Monday morning stuff. It's got to be stuff that people can get out there, use, see results from, and help change people's lives with. And that's sort of the main driver of the platform.
Yeah, and it's great that you're going to get other practitioners on there because we can learn a lot from what other people do, as I know you mentioned earlier. Brilliant. Thanks again.
Thank you very much.